Hello, I'm Professor Shane Dark from the National Drug and Alcohol Research Centre at the University of New South Wales, and welcome to our lecture series on drugs and the body. Now, today we're going to be looking at the hypnosedatives and a group of widely prescribed and widely used drugs that have major clinical implications. Firstly, before we go into the effects of the hypnosedatives, we should define what we're talking about. What are they? Well, they're also known as sedative hypnotics. They're a group of central nervous system depressants. That is, they are, in colloquial terms, downers. They operate on the GABA systems, they're GABA agonists, which means they reduce excitation, which is consistent with what we've just said about being downers as such. They're widely used in medicine for treatment of anxiety disorders, insomnia, so anxiety, the sedative effect, insomnia, the hypnose effect, that is causing sleep. They're used also in managing withdrawal from drugs, for instance the opiates, to reduce the severity of the withdrawal syndrome. Also used on occasions as for anaesthesia, drugs like midazolam, for example, and for the management of epilepsy. So there are drugs with a wide clinical use. When used within clinical standards and on advice and well managed, they are not necessarily going to cause harm. And much of what we're going to talk about is about the misuse or abuse of these drugs. Let's have a look at the types of hypnosedatives that we're going to be discussing. There's three major classes that fall under this term. The most widely used and most widely known for viewers, of course, are the benzodiazepines. I'm thinking of drugs here such as diazepam, temazepam, oxazepam. These are widely used, diazepam frequently sold under the brand name Valium, for example. They're widely used for the treatment of insomnia, anxiety and withdrawal syndromes. The second major class are the Z-class hypnotics. The major drugs here are zolpidem, which is frequently sold as Stilnox, and zopiclone. They're similar to the benzodiazepines and they're used for the treatment of insomnia, but they are distinct as a class from benzodiazepines. The final one are the barbiturates, and I'm thinking here of drugs such as phenobarbital and pentobarbital. These were widely used in the mid-20th century, and there was great concern about their abuse potential and toxicity, which led them to be phased out in the latter part of the century. They're primarily used now for induction anaesthesia, particularly drugs such as phenobarbital, and for the management of treatment-resistant epilepsy. These are the three major classes. Of those, barbiturates are rarely prescribed in general medicine these days, and the most common would be, of course, the benzodiazepines. Let's look at the acute effects. Not surprisingly, a drug that is prescribed for insomnia causes drowsiness, which is why it's prescribed. However, they do have effects such as respiratory depression. This is a common effect of all depressants, downers, including the opioids, and of course the effects when you use these drugs with other drugs are exacerbated, other downers. Muscle relaxation, they're sometimes prescribed for spasms, particularly diazepam. They cause discoordination and disinhibition, two factors that can be associated with an increased risk of injury. and amnesia. This can be quite profound in some cases at high doses, that people have acute amnesia while intoxicated with these drugs. And these, of course, these effects are magnified when they're used as drugs for intoxication rather than for medication. They have a very high dependence potential. Benzodiazepines in particular came out in the 1960s, and they gradually replaced, the Z class came a little later, they gradually replaced the barbiturates. Now, at the time it was believed, and this is the case for any new drug that comes out, we've seen it for the gabapentinoids, that they had low dependence potential, unlike the barbiturates. This is not the case. Any drug which has sought-after effects has dependence potential. And one of the factors that comes out of this, that the benzodiazepines in particular are common drugs of abuse, used for intoxication, frequently used by, for instance, primary opioid users to magnify the intoxication, and also by, say, psychostimulant users, methamphetamine users, for example, for a different reason, to take the edge off the stimulant effects and to aid coming down from an amphetamine high. I should point out that while these drugs are typically oral preparations, injecting drug users are well known, or frequently a large proportion grind the tablets up and inject them, which is a particularly high risk behaviour, as these are oral preparations not meant for injection. And we will be looking in a different lecture at the harms associated with injecting drugs. All of these types of sedatives have a withdrawal syndrome. When there is a dependence syndrome, there's typically a withdrawal syndrome. In the case of the benzodiazepines and other hypnosedatives, this is a possibly severe and even lethal withdrawal syndrome. It needs to be managed medically. We do not ever recommend people just suddenly cease using their drug. If they've been prescribed this, particularly for a long amount of time, tapered withdrawal is what is required, not abrupt cessation. The withdrawal syndrome can be associated with a range of physical effects, most particularly seizures and fitting, muscle pain, tachycardia and accelerated heart rate, and tremors. Of those, of course, it's the seizure and fitting that can cause major harm. And as I said, this can be potentially fatal withdrawal syndrome. In that manifestation, it's very much to be treated like an alcohol withdrawal syndrome. These are serious withdrawal syndromes that require medical attention. There's a range of psychological effects that can affect the patient and actually may have them go back to use. Intense agitation during withdrawal, anxiety and panic attacks, and of course, remember some of this. These were the reasons that they were given the medication, so we could get this recrudescence of these effects. Depersonalisation, this loss of sense of self and reality. Depression, very common. Hypersensitivity to light, sound and touch, and insomnia. And again, of course, in many cases it was insomnia that the drugs were given to treat. There's a takeaway message here, is that there is a withdrawal syndrome. It can be severe and it needs to be properly managed. Let's now look at the toxicity associated with the hypnosedatives. The major risks here are the risks that are associated with all of the CNS depressants, and that is respiratory depression, the brain forgetting to tell the body to breathe. And in overdose, this is the major cause of death, as you would see with the opioids. Associated with this is aspiration of vomit, there's breathing vomit into the lungs. This is most pronounced for the barbiturates. They are by far and away the most toxic of these drugs. And this was the reason that the high dependence potential, because they're so powerful, and their toxicity and high risk for overdose and death is what led the barbiturates to be phased out of general practice and only used in very particular manners. I said before that many opioid users, for example, use benzodiazepines and other hypnosedatives. When you put together a number of different CNS depressants, the risk of respiratory failure is substantially increased. The dose for any one of those drugs, for instance, heroin and diazepam, may both be subtoxic, but put them together and they may cause an additive effect that causes respiratory depression and possibly respiratory failure and death. The major ones of concern here are alcohol and the opioids. People using CNS depressants need to be aware that putting them together is not a harmless behaviour, and clinically, if there are, of course, legitimate reasons to be giving opioids, for instance, for pain and drugs such as diazepam, but the risk needs to be recognised and it needs to be managed. The Z-class hypnotics are curious in that there's been numerous reports of dissociative behaviours associated with them, fugue states. That is, people having no awareness about what they're doing, getting in a car and driving for miles and then afterwards having no memory of driving or being in the car or while they were there. People phoning and sending texts or breaking into houses and rummaging through people's wardrobes, completely no realisation of what they're doing. Now again, this is not something that I'm suggesting everyone who uses Z-class hypnotics is going to experience, but there are some idiosyncratic reactions that have been well documented, and of course the misuse or use of these drugs in high quantities would increase that risk. The barbiturates have been not widely used in the last 20 years or so in general medical practice, and their street use has gone down. So that is, they're not widely used amongst drug users and they're not frequently seen in people turning up for treatment for dependence. What they have become, however, is drugs that are widely used for suicide by people who are seeking to end their life. And these have been marketed on the net in particular, and what we have seen is that the number of suicide cases with barbiturates involved has increased markedly, and that has not been the case for either treatment or hospitalisations generally. These are highly toxic drugs, and people who are seeking them from a clinician, there's a high index of suspicion here that it may be for use as a drug to end life. Let's now turn to looking at the brain. Hypnosedatives are not neurotoxic. They do not cause brain cell death directly, and they're not associated with an increased risk of stroke. So this means, of course, this is a great positive if one's prescribing these drugs, but even with the abuse of these drugs, there is some comfort there. They're not associated with seizure while use is maintained. As I've said, the withdrawal syndrome is potentially severe, and sudden cessation may induce fitting. That just needs to be emphasised, that abrupt cessation is not the way to go for someone who's dependent upon hypnosedatives. They need to have a tapered withdrawal regime. Now, I said that the drugs do not cause direct toxicity to the brain, and that is certainly true. But as with all depressant drugs, acute anoxia in overdose is a problem. That is, the person overdoses, their breathing suppressed, they're correspondingly less oxygen to the brain, and in overdose this may be associated with hypoxic brain damage. This is the same type of risk that we see with drugs such as the opioids, and in high doses alcohol. Let's have a look at mental health, psychopathology. There are elevated rates of affective disorders, mood and anxiety disorders amongst people who use these drugs, but it must be borne in mind that we would expect that because these are one of the reasons the drugs are prescribed. We need to keep in mind, with the rates of depression seen amongst regular users, or certainly abusers of these drugs, the risk for deliberate toxicity when you're prescribing these drugs, and consider which types of drugs you would be willing to prescribe. As I said previously, if someone's being prescribed the barbiturates, for instance, for epilepsy, care should be taken in terms of inquiring after suicidal ideation. As we mentioned before, the withdrawal syndrome is associated with numerous well-documented psychological effects: intense agitation, anxiety, depression, dysphoria, and suicidal thoughts. I think this just emphasises again the withdrawal syndrome is something that needs to be monitored, and it's not simply the effect of the drug on the brain in terms of seizures, for example, that's of clinical relevance here, but the possibility of people developing suicidal thoughts and depression, and this needs to be closely monitored. And finally, let's look at other hypnosedative related conditions. These drugs cause drowsiness, discoordination, disinhibition and amnesia, particularly in high use abuse. What this does is elevated the risk for traumatic injury. In particular, motor vehicle accidents. If someone is abusing these drugs and driving, it's the same for any drug. Intoxication is always bad for driving. It never improves driving. The person who's taken a large dose of, say, benzodiazepines and is driving may feel calm and confident, but their driving will be severely impaired. The other risk is falls, and this is particularly true amongst the elderly. Increased risk needs to be borne in mind, and this is true even within prescribed doses. There is increased risk for the elderly, and dosage needs to be carefully monitored with older patients. Thank you for watching this presentation on the hypnosedatives. We've covered a large range of issues, clinical and otherwise, and all of these are covered in our book, The Pocket Guide to Drugs and Health. This is a page at a glance summaries of all of the issues we've discussed. It covers all of the major drug classes and the effects on all of the major body systems and the brain.